I'm Dr. Fiona Lovely, and this is the Not Your Mother's Menopause podcast. I'm taking the taboos of menopause and peri-menopause and bringing light to the dark. No bullshit, no shame. It's time for us to gain a new paradigm in female health, out with the old and in with the new, and I'm bringing fresh perspectives from someone in the arena. I've been practicing women's health for nearly 20 years, and I'm spilling the tea on what it means to live at midlife, knowing that the best is yet to come. I'm sharing my Gen X approach to living through this transition. Sassy, a bit sweary, and always honest. Tactical tips and instantly usable information is my aim. I hope to make you laugh and that you learn something new that helps you embrace the change. Together, we bring power to the peri. Onward to the podcast. Hello, listeners. I'm Dr. Fiona Lovely. This is the Not Your Mother's Menopause podcast. And today I want to introduce to you a book called Unbreakable, A Woman's Guide to Aging with Power by the one and only Dr. Vonda Wright. And if you're anywhere near social media, you'll know exactly who this is because Dr. Wright is on those platforms teaching us every day the things we need to know to keep well physically at perimenopause, menopause, and for the rest of our lives. And I've been looking forward to this conversation, and she and I had a vast conversation about how menopause ultimately changes us physically, not just bones and muscles and tendons, etc. We talk the science, and then we get into some of the remedies, we get into the spiritual aspects of menopause, and we talk about what it's like to be a female practitioner in male professions, really. Dr. Wright is an orthopedic surgeon and longevity specialist, and we had a great time. It was a wonderful conversation. And if you've wanted to know what it means to your physical tissues, meaning your bones, your muscles, your tendons, your ligaments, your intervertebral discs, your nervous system, what happens to these tissues when we lose estrogen, she and I are going to talk about it. And more importantly, go get the book. Unbreakable is available today, August 26, 2025. It is a woman's guide to aging with power. I can't wait to introduce my guest to you. Dr. Vonda Wright is a double board certified orthopedic surgeon and internationally recognized authority on human performance, longevity, and women's health. The founding director of the Performance and Research Initiative for Masters Athletes, she has served as a physician for athletes at the University of Pittsburgh, Georgia State, the Pittsburgh and Atlanta Ballet, World Rugby, and the PGA. A highly sought-after media expert, she's been featured on The Diary of a CEO, Jay Shetty and Mel Robbins podcasts, as well as The Today Show, The Dr. Oz Show, and in top publications including The New York Times, USA Today, and The Observer. She has authored 5 books, including Fitness After 40 and Guide to Thrive. She lives with her husband and a retired 2-time Stanley Cup champion near Orlando, Florida. So if you want to know more about why it is you're achy all the time, why your joints hurt, why your muscles hurt, why you're losing bone, why you're losing muscle mass, this is the conversation for you, and this is the book for you. I can't wait for you to listen to my conversation today with Dr. Vonda Wright. I have a wonderful guest joining us today on the show, Dr. Vonda Wright, longevity specialist and orthopedic surgeon. Welcome to the Not Your Mother's Menopause podcast.
Thank you so much for having me.
Oh, you're very welcome. I've been waiting for this conversation for a good long time. I have to cop to being somebody who has had your research paper on my nightstand, on my clinic desk, and on my computer desktop since it was released in July of 2024.
Yeah.
So thank you for being part of the team that put this together. For 20 years, I have taken care of women in clinic and wondered, why is it that I keep seeing the same things at the same age? Frozen shoulder, plantar fasciitis, sore knees, gluteal tendinopathies.
That.
Yes.
Yeah.
And you have put a name to it and called it the Musculoskeletal Syndrome of Menopause. How did you get here?
How did I get to that paper or
Yes.
yeah, I started listening better to my patients. I went through my own cataclysmic peri-menopause experience. And then in that, became an expert in all these things. And in doing that, became able to listen to my patients better. And they would come to my office and say a variety of things, but inevitably we would get to, you know what? I think I'm falling apart. And I think I may be going crazy because people tell me there's nothing wrong with me. I'm just aging. But you know what, doc? And this is the part that breaks my heart. You know what? I have a high pain tolerance, as if it's a button that we wear, high pain tolerance.
Mhm.
But I didn't want to come in, but I had to because I can't take it anymore. And woman after woman after woman, I'm a smart girl. I start putting the pieces together and start doing the research and realizing that every single musculoskeletal tissue, which for your listeners who may or may not know this, all musculoskeletal tissue, uh, tendon, ligament, cartilage, bone, fat, muscle, muscle derived stem cells, annulus of the spine, all come from the same stem cell. So why do we expect that what happens to one wouldn't happen to another if they all have estrogen receptors? As my little left hand is always the estrogen receptor. And when there's no estrogen sitting in the basket, none of the marvelous protective and anabolic things that estrogen does normally will happen.
The AG1 you've all heard me talking about for so long just went through a major upgrade. AG1's next gen is here. It's the same single scoop once a day, but now it's clinically backed and formulated with more upgraded vitamins, minerals, and probiotics. The new next gen formula offers a more advanced, clinically backed formula that fills common nutrient gaps and supports gut health, all in the same easy, once a day ritual. AG1 has been a game changer for my mornings. It sets the tone for my day, helps me feel my best, and like I'm taking care of my nutrient needs in one step. AG1's Next Gen includes 5 clinically studied probiotics and additional vitamins and minerals to support whole body health. Now clinically backed with an advanced formula, this is the perfect time to try AG1 if you haven't yet. I've been drinking AG1 daily for 6 years now, and I'm so happy to be partnering with them. Subscribe today and try the next gen of AG1. If you use my link, you'll also get a free bottle of AG D3K2, that's vitamin D3K2, an AG1 welcome kit, and 5 of the upgraded AG1 travel packs with your first order. So make sure to check out drinkag1.com. That's drinkag1.com/Fiona Lovely to get started with AG1's Next Gen and notice the benefits for yourself. That's drinkag1.com/Fiona Lovely.
And so as I started listening better, it occurred to me that in the same way, when Rachel Rubin and her group put all the symptoms of genitourinary syndrome together, it gave women a nomenclature for them to be able to present to their doctor's office and actually have a conversation. Because if anyone goes into a 15-minute doctor's visit and says, my shoulder hurts, my knee hurts, my left elbow hurts, my foot hurts, there's not enough time in a 15-minute day to get to that. But if you go into someone who's read this paper's office and say, I'm 46 years old, I think I have some of the musculoskeletal syndrome of menopause, it gives us a nomenclature for communication. And you know what? We were right, because we knew this was going to take off great because of the great need of women, but we didn't realize that. The other day, out of my vanity, I looked up how many times this paper had been downloaded in 1 year, because it's about its year anniversary. over 418,000 times. Women have done what you did. They brought it off, they read it, and then for lay women, they take it into their doctors to start a conversation. To put that in context, there was a study done. The best papers in the biggest journals, like the British Medical Journal, the Lancet, the JAMA, the best papers are by and large downloaded 10,000 times. And 50% of all good research is never read by anybody but the authors. So what that tells us, okay, I could cop to, oh my God, best paper ever written. Not the truth. It's a great paper. That, in my mind, points to the tremendous unmet need of women that we care for. That is why this has had such a big impact.
Did you say 410,000 times?
418,000 times. 6 zeros, 6 figures, people. Wow. Yeah. And, it's just because we need words. Like, we need to know what perimenopause is. We need to actually know what menopause is. I still have women every clinic that have never heard of it. Right? So we just need the words and the common language. And that's what that paper was about.
It's beautiful. And, I've shared it with my professional colleagues, the other doctors in the office, and the physiotherapists. So we all have a new language that we're able to use. And we're not just so often when we're working to apply therapy to, let's say, a frozen shoulder, there's a lot of spinning wheels. There's a lot of time. It takes time for these things to resolve. But now we have new tools. We can look at applying estrogen to this because it is a problem of the estrogen regression. Can you talk about what happens to our musculoskeletal system when estrogen starts to leave the building?
Well, one of the first things that happens is, or not the first, a common thing that happens up to 70% of the time. And I had this. I'm an athlete, but there came a time when I could barely get out of bed because of arthralgia, which means multiple joint inflammation and pain. And women arrive with this and they're labeled with fibromyalgia, they're labeled with seronegative rheumatoid arthritis. And sometimes it is seronegative rheumatoid arthritis. But instead of putting someone on methotrexate, maybe we should try a little bit of menopause hormone therapy first to see if we can resolve this, right? Or instead of slapping a woman with a lifelong diagnosis of fibromyalgia, which is just a diagnosis of exclusion most times, why don't we think a little further? And then if we get to the point where that's all that's left, okay, fine, let's call it that. But when people arrive with total body pain of arthralgia or a frozen shoulder, meaning out of nowhere, you didn't hit your shoulder on the door, you didn't pick up a heavy load, it's just painful. And then within a week, you can't hook your own bra. That is due to the profound effects of estrogen on the immune system and specifically regulating inflammatory cytokines and a molecule within the immune system called the inflammasome. So sometimes I get feedback, usually on the internet, of people who need to read more papers. It's interesting to see what people think.
Of course.
Who need to read more papers, and they're like, yeah, that's not it because men get frozen shoulder too. Well, they do. What men get frozen shoulders? Highly inflamed, out of control diabetic men.
Yes.
It's the same inflammatory situation, right?
Yes.
So arthralgia, frozen shoulder, inflammation. Why do we get Achilles tendonitis, plantar fasciitis, tennis elbow? We don't even play tennis, right? Some of us, right? Or golfer's elbow. Well, that's because estrogen is critical for maintaining the health of ligament and tendon. And without it, ligament and tendon have a hard time repairing themselves anyway, but we have more rapid degradation of those. Same with cartilage. Cartilage, structurally on the end of the bone, every bone is covered by this end cap of glistening, white, smoother than ice tissue that is a matrix. It literally is a sponge with little cartilage cells sitting in it. Well, estrogen is critical for maintaining the integrity of that matrix. And without it, that matrix and therefore cartilage rapidly declines, such that women after 50 have much more rapid progression of arthritis versus prior to 50, men have more arthritis, right? And so all of those things, plus difficulties with muscle protein synthesis. We don't make muscle as well. But let's talk about bone. Bone, last about a year ago, bone has never been sexy, except to those of us who love bone, but it's never been sexy unless you're looking in the mirror and you're like, oh, the cheekbones, or
Cheekbones,
it's Fashion
yes.
Week. We're looking at all the bones. The reality is, I set out on a mission to make bone sexy in pop culture. And so I started talking about it on every podcast and saying, okay, so you guys think the bone is just structural, holding up quivering masses of muscle, but bone is actually a master communicator that through the hormones that it produces, such as osteocalcin or LCN1, it controls satiety. It controls how much we eat. It controls our glucose balance. It controls insulin. It controls how it helps our brain make brain cells. And if you're a man, it helps your testicles make testosterone. And when you say things like that, it puts bone in an entirely new light. And you think, oh my God, I have got to do something to preserve bone, because what do we know about when estrogen walks out the door? We will lose 15 to 20% of our bone density in the 5 to 7 years of peri-menopause. That is no good. That is no good. So we are bringing bone to the forefront, because muscle's fine, but a bone is as critically important.
No, I certainly was never taught that bones were sexy in school, but I love what you're saying, and I totally agree with you. There is something to be said about making sure that we're keeping our bone structure healthy as long as we can. The joke that I make in the office is that the bones are not just a hanger for your meat suit. They actually have real function, not just the storage of calcium for heart and thyroid and everything else. But, the question I have for you is when you were talking about frozen shoulder, men versus women, I remember in my training in school 25 years ago now, I remember them saying, here's who gets frozen shoulder, 40-year-old women. That's what we were taught. But we weren't taught why, and there was no discussion of how hormones affect the musculoskeletal system. And for somebody who's in training to be an expert in such things, it's so amazing to me that that was completely absent. And I wonder, did you get any training on the difference between men and women? And potentially, was there a midlife or hormonal situation involved there too?
No, I was never trained. Well, let me take that back. I was never trained in my orthopedic training. However, I had the great fortune of being part of a stem cell lab at the University of Pittsburgh. And then I had my own translational research lab. And in that lab, we did look at the sex differences of various cells. So in that lab, for instance, we were studying the capacity of what at the time we were calling muscle-derived stem cells. I think they're satellite cells is what we're, the more common satellite cells. But we were looking at what we could make them do, because you can take a cell with a potential and put them in different environments and see what they do. So we took male cells from XX animals, female animals, and cells from XY animals, male animals. And under the same conditions, they did different things. For instance, muscle stem cells from XY boy mice make bone better. XX stem cells make muscle better, make cartilage better. So when we kiddingly say, there was that book so long ago called Men Are From Mars, Women Are From Venus, that's actually true down to the cellular level. So I was never taught that in med school, although we were beginning to be cognizant of it. But why would we be taught, any of us? Because not until 1993 were XX people required to be in research studies. Medical research was not required to include women until 1993. So that wasn't that long ago. So why would any of us have been taught? Because there was an assumption that what was good for 40-year-old white men was good for everybody, including men of different races. And that's just not the truth. So no, not taught, still not taught, still difficult to get orthopedic surgeons, bless their heart. I love them to listen to this. But it really, if they would stop and think about it, osteoporosis is critical for their practice because, this is the actual rod I put in people's femurs when it breaks. This will not stay if you have ghost bone. You cannot get this big screw to stay without cutting out unless you have good bone density or decent bone density. It's the same for the little screws we put in or the big metal end caps for total joints. I mean, musculoskeletal doctors do need to think about these things, but we've never been taught. And actually in 2011, my mentor, Joe Hannafin, who is at the Hospital for Special Surgery, went to the trouble of, in her patients with frozen shoulder, biopsying their shoulders to see what the different stages of the inflammation were. And she identified 4 different stages, from pain to freezing to thawing, and what was happening at a histologic level. But the reality was, in her discussion, she said, and this seems to happen to a cohort of midlife women, more research is necessary. So research is still necessary. Less than 1% of all NIH-funded research is done on women over 40.
Less than 1%.
Less than 1%.
Wow.
I mean, the percentage in women at all is abysmal. But then when you get women over 40, it's almost non-existent.
Wow.
And things are changing. The Gates Foundation just donated $2 billion towards this. So
amazing.
So the needles are being moved, but the reality is, for all history, women have not been studied. So why would doctors know?
No,
why
of
would
course.
we know?
Yes. Hopefully that's changing, as you've said, and as we, graduate more contemporary professionals, we'll have a much better idea of what to do with this. So, if a woman is showing up with, let's say, plantar fasciitis or frozen shoulder, we can pick whichever one. What do we need to consider? Is it a matter of, do we just need to put estrogen back into the system? Or are there other things we should be looking at in terms of the musculoskeletal syndrome of menopause?
Well, I don't think it's ever going to be one thing. It never is one thing. I mean, we are very complex organisms. We need to create ecosystems. So when I talk about people and I like to make up words. So I made up the musculoskeletal syndrome of menopause. I also made up the concept of the menolescence, meaning throwing an eyeball at adolescence when we come into our hormones and it's chaos. We all know what that is. We all know it's going to be rough for a while. And then we all know we normalize out of it by doing a lot of things. That is the concept of menolescence, which is hormonal, physical, psychological, brain chemistry, and it's social. So it's never going to be one thing. So if a person comes into my office with a frozen shoulder, I know what they have. I take the white chart out of the door. 46-year-old, 51-year-old with shoulder pain. I know it's going to be a frozen shoulder, because 40-year-old women generally don't get rotator cuff tears.
Exactly.
Right?
Exactly.
So I know going in probably what it's going to be. So I don't actually start with the shoulder. I start with how they're feeling, how they're sleeping. And as I start to peel the onion, whatever analogy you want to use, women inevitably start crying. And it's not because I'm a mean doctor. It's because for the first time, someone is recognizing that they feel like shit. And no one is listening, and they can't sleep and haven't slept for years, and all the things. Because when I approach it like that from a whole person doctor standpoint, they know I'm listening, and therefore they are more likely to be consistent with our treatment plan. Plus, I think women deserve to be listened to. So once we unwrap that, I start to talk about the role of estrogen on the musculoskeletal system. Because if I just launch with, it's your estrogen, you're out of estrogen, that's such a wild concept to most people that it's too big of a leap. But when we talk about this stage of life and then connect estrogen into it, so then when we talk about frozen shoulder, and again, I don't start with, we're going to physical therapy, but we are going to physical therapy. I start with, this is the time where it's very important for you to become highly educated on this stage of life. And so I give them references to read. And I physically handwrite notes for each of my patient because it slows the visit down. And I give them my scribbly pieces of paper. Literally, it would be something like this, right? Here's your scribbly. Because I'm not going to hand you a photocopy of something and say, read it. I'm going to say, this is your plan. I have handwritten it out. The first thing is we talk about menopause hormone therapy, what it is, where they get it. If they need the data, I suggest Estrogen Matters, the book.
Yes, excellent.
Right?
Yeah.
If they need an education, if they need an education on menopause, I hand them The New Menopause by Mary Claire Haber.
She's been on the show.
Let's educate ourselves. Then we get to, for your frozen shoulder, so you're going to make your menopause hormone therapy. If you need me to tell you where to get your hormones, I will do that for you, as I'm saying this to the ladies and their husbands who are often in the room. And then we say, I explain what a frozen shoulder is. We're going to go to therapy and therapy and therapy. And my therapists have become very, very good at this, because it's not ballistic stretching. For a frozen shoulder, you need very long hands-on. It's not modalities. So if you go into a therapist's office and they just stick a bunch of electrodes on you and walk away, that's not how a frozen shoulder goes away. And it takes manual therapy and slow stretching.
Yes.
Hanging is the best, actually, if you can get the arm up there to do it. So therapy. I give very few steroid injections. I am not an orthopod that believes in steroids. There's so little data, but we will use it to get them over the hump in shoulders. Like if they're like, I can't stand for you to touch my shoulder, let alone do therapy, I'll give them a steroid injection so they can tolerate it. But that's not the whole conversation. We need to completely anti-inflame the body. So we talk about smart nutrition. We talk about protein. We talk about completely eliminating added sugar. So as you see, 15 minutes is never enough. But B, this is a whole person discussion. Not just let me shoot your shoulder and send you to therapy. Because unless you understand the origins, you're not going to change your diet and become uninflamed and, change your pre-diabetes, which is probably contributing to this. You are not going to seek out your estrogen answer, which is the real answer to this, right? And you may or may not go to therapy because it hurts.
So this is not what people expect out of a visit to the surgeon.
Well, I think you're right. Some surgeons have earned the reputation of being cutters. But I am going to tell you for sure, I trained at the best houses in the world. I trained at the University of Pittsburgh, one of the leading orthopedic places in the world. I trained at Hospital for Special Surgery, leading the number one orthopedic hospital in the world. I learned this from my mentors.
Amazing.
The best surgeons in the world listen to you. In fact, the best sports surgeons in the world give you their cell phone number when you operate on them.
Wow.
That is, so if you're not getting that, well, then ask yourself, are you getting a technician or are you getting a doctor, a surgeon?
Fascinating. I love this approach. Absolutely. So for usability for the listeners, what are the parts of the musculoskeletal syndrome of menopause?
Yes. So obviously it can go on forever because I do. So we talked about arthralgia, frozen shoulder, which is the inflammatory part. We have talked about the tendonitis and tendinosis, right? So all of those things that we named previously, plantar fasciitis, Achilles tendonitis, patellar tendonitis, anterior knee pain, elbow pain, rotator cuff tendonitis, the dreaded, my butt's so weak that I can't fire my glutes and I get glute tendonitis, right? That's miserable. All those itises. We lose muscle mass. It's a normal part of aging, but it's accelerated. We lose bone density. We've talked about that. We lose stem cell viability. We know that we can rejuvenate stem cells, our muscle stem cells, by something as easy as exercise. I've done it. I mean, I had a lab. We stuck old lady mice on treadmills and looked at the health of their stem cells, and lo and behold, if you want the fountain of youth, it's exercise. It literally is. And then something I left out of the paper, which I shouldn't have, but I did, is this will be near and dear to you, in the discs of our spine that separate the vertebrae, that cushion the vertebrae. for your listeners, it's like a jelly donut with a hardish outside and a gooey inside, right? So the annulus, the hard outside of the disc, has estrogen receptors and reacts like all the ligaments and tendons with the itises. It can't repair itself as well without estrogen, which contributes to this pandemic of low back pain we have in this country from sedentary living.
Yes, absolutely. Oh my gosh, it's 90% of my work. So my question to you is because I've seen that research that you're talking about the intervertebral disc and how it is affected by the hormonal changes at menopause. So tell me your thoughts on leaving that out of the musculoskeletal syndrome of menopause, and maybe is that part two for the research?
It might be. It was a mistake. It wasn't intentional. Yeah. The paper, I don't know how old the paper of it may have come out after I'd written the paper. I can't
think
remember.
it's fairly old, actually.
Oh, is it? Yeah.
Yes.
Well, you know what's fairly old? The knowledge that cartilage is dependent on estrogen. That is a 30-year-old paper. It's called The Arthritis of Menopause. Has anybody in the modern era known that? Not so much.
Nope. When your paper came out last year, I went about looking at what was similar. Because when you're going to PubMed and you're at the bottom and it tells you the different things that are similar, I found that paper, The Arthritis of Menopause, and thought, holy shit, where has this been? This could have been incredibly useful. This is 51% of the population. And in a clinic like mine, I'm going to say probably 80% of the patients are actually women who then get well and then send their families in. So this is really important stuff. It's really,
yes. Yes, it is.
And not just because it's two musculoskeletal nerds talking about it, right? This is incredibly important. And I want to segue into what I'm going to guess is probably one of your favorite / not so favorite things to talk about is frailty and the prevention of frailty. Can we go there, please?
So, every day women say this to me: I don't want to age like my mother or my grandmother. And I know what that means. And, unfortunately, at my advanced age, I still have to take call. And so I'm the one meeting frail women who have fallen and taken their fatal fall in the ER to stick metal rods in them. I mean, this is real life to me, people. So frailty is the point in your life when you can't do what you want when you want to because you can't get up from a chair, right? There's a point. I mean, if you want the hard numbers, so the concept of sarcopenia and frailty are not just how much muscle mass you have, it's a functional measure. Can you get up from a chair? There's a VO2 max after which your fitness is so low, you cannot get up from a chair. Well, what are your choices? Live with your kids, have a full-time nurse, or go to a nursing home.
Oh my God.
I mean, it forces the decision, right?
Yes.
So we never want to get to the place where we can't, at the very least, walk around our own home. But 2/3 of all people living in nursing home are women. So lots of women get to that place. And so frailty may seem like something in the distant future, but I want to bring it up to here.
Yes, ma'am.
Can you get up from a chair without holding the sides of it like this? Can you just pop up? Lots of women in our age demographic cannot do that. Have you ever been to the airport and seen all the youngish people who have difficulty traversing those distances and are in wheelchairs? Yes. Now, they probably have lots of reasons for that. But I assume that a percentage of them just aren't fit enough to walk a half a mile in an airport, right? And so if we bring it from the distant future with our grandmas to today, and we start doing an honest inventory of what we can't do. Can you open a pickle jar? Can you go up and down stairs without losing your breath? Can you get up out of a chair with no hands? Sometimes I put challenges out on my social media that are not made up. I mean, when I put out the push-up challenge, that is part of the American College of Sports Medicine guidelines, it got some really interesting participation, meaning millions of women challenged themselves, and some feedback, because surprisingly, that's hard. Holding up your own body weight. But why is that important? Well, it's important for safety in your home. It's important. I'm in scrubs. I got out of the OR right before this. We bring people into the OR on one gurney, and then they have to transfer themselves over onto the operating room table. And it is not uncommon for people to not be able to lift their own body weight with their arms, like scoot over. They can't scoot over. That's dangerous. It's not a judgment, it's just pure danger, right?
Yes.
So when we talk about frailty, it can be a concept for the distant future, the end stages of it, but it begins when we're young. And so when I talk about building shields against the time bombs of aging, that I am talking about building muscle, building bone, correcting our metabolism so that we're building shields against this frailty, which can become inevitable. If we do not step in front of it, it can become inevitable. So, and nobody wants that.
No. And there's so much we can do to prevent that.
Absolutely.
But that's why we're bringing it up now, is so that we can do it before it becomes a problem. I talk about Dr. Peter Attia's centenarian decathlon on the show quite a bit. If you're not familiar with the concept, what he says is train for the life you want to have when you're 90 or 95. Do you want to be lifting your groceries? Do you want to be getting up and down off the floor? Do you want to be taking the stairs? Do you want to be, playing with your grandkids or your great grandkids, and then go to where you are now and train for that. And I think that's a pretty neat concept to do that. And it's essentially exactly what you've just said, is look and think about what you can't. Maybe you're looking at it saying, okay, I can't do the push up or whatever it is, or that's the thing you train for. It's actually a pretty elegant way to do it, don't you think?
Sounds good.
Yeah. I love it. All right, let's talk about skincare, because as a doctor, I often hear the same frustrations from women. Many clean or natural skincare lines sound wonderful, but let's be honest, they frequently lack the ingredients that actually trigger real visible change in your skin. And for those of you who aren't quite ready for the Botox route just to feel and look younger, what can you do to truly tackle fine lines, texture, and age spots? This is what I want to know too. Here's the truth about aging skin. A significant part of those signs you see, the dullness, the lines, is simply a buildup of dead or damaged skin cells. If we can genuinely improve how your skin efficiently clears out those old cells and regenerates new ones, we can actually reverse aging, not just mask it. And that's precisely where Young Goose Skincare comes in. They've done something brilliant. They've merged the best of natural skincare with medical grade science to create what they call biohacking skincare. This isn't just about surface level improvement. It's clean, it's remarkably effective, and it's designed to penetrate your skin barrier to trigger fundamental change right at the cellular level, helping your skin truly function younger. While other brands might talk about reducing the appearance of aging, Young Goose goes deeper. Their formulas are specifically engineered to reverse the signs of aging by targeting the root cause in your skin, delivering real results. Now, how do they achieve this? Of course, it's by leveraging powerful science-backed ingredients like NAD boosters. They're included to recharge your skin's cellular energy and support vital collagen production. Spermidine works to activate autophagy, which is essentially your skin's natural process of clearing out old or damaged cells. They use senolytics to help remove those aging zombie cells that can actually slow down your skin's natural regeneration. And their copper peptide complex with neuropeptides is fantastic for improving elasticity, firmness, and visibly reducing lines. They also include many more cutting-edge ingredients that boost your skin's regenerative processes. This isn't about a quick fix. It's about genuinely changing the way your skin functions. This means it can heal more effectively, regenerate consistently, and ultimately stay youthful over a long period. So if you're ready for skincare that genuinely works and delivers on its promises, I highly recommend checking out Young Goose Skincare. You can find the link directly in the show notes or go to younggoose.com/lovely. That's younggoose.com with code LOVELY for 10% off your order. I use these products myself, and I can tell you they make all the difference in the world. Check it out. Okay, so preventing frailty is not just about can we get up off the chair? It's preventing things like a broken hip. And we know that when a woman breaks her hip, help me with the statistic here. What is the chances that she's going to have, the likelihood that she's going to survive even the first year after a hip fracture?
Yeah, these data are for both men and women, but they're more profound for women because 70% of all hip fractures happen in women. So the moment, and I just testified before the FDA on these very data, the moment, like snap your fingers, the moment you fall and break your femur, the femur is the largest bone in the body. It's not easy to break. So you either trip and fall and break your femur, or there are some femurs that are so weak that they break and then you fall. It doesn't matter. The moment it happens, you incur a 30% chance of dying in 1 year and a 50% chance of never going home, meaning you can't take care of yourself anymore. So again, the choices: do you hire somebody full-time to live with you to take care of you? Do you move in with your kid, usually your eldest daughter, because that's usually who takes over care of the family? Or do you move into a nursing home? I mean, those are the sad truths. And then here's the saddest truth. Nursing homes or assisted care facilities cost an average of $7,000 to $15,000 a month. That's expensive for most people of any means. So what happens is you burn through your life savings paying rent in a nursing home until you are a pauper, and then you're eligible for Medicaid. And the country takes care of you. That's probably not how you planned your life. No. And when I say things like this, I just want to address, I'm not fear-mongering. I am not being threatening to your audience or anybody else when I say these people are like, why are you scaring us? Numbers don't lie. I'm not scaring you. If you're scared of these numbers, then let's act to not become one of these numbers. Because this is what I see every day when I have to take call and meet a family in the ER. I don't want to meet them there. I'd rather meet them at a restaurant to have dinner with my neighbors, not meet my neighbors in the ER to suture them together. Does that make sense?
Of course it does. And, I think sometimes we have to get the hard news in order to have the wake-up call to act. And I sense the passion in that. Let's reach the women before they're on my operating table. What can we get them? What information can I share with them before they become my patient?
Well, and there's a lot of emphasis, and I'm as vain as they come. So I'm judging myself too. There's a lot of emphasis on fitting into the little black dress or potions and lotions and for the appearance of youthfulness, but nothing is more youthful than doing what you want to do when you want to do it in good health, right? It's not about the little black dress. It's not about how wrinkleless my skin is, no matter how much I wish I could get rid of some of this, but it's not about that. My youthfulness is the fact that at my age, without worrying about it, I go do Spartan races or I jump off of boxes. That is youthfulness to me. And that's my wish for everyone who comes in contact with me.
Yeah, we didn't know until we knew. And that's what you're doing. You're showing us the things that we're not even paying attention to as a society. We're thinking it has to do with, wrinkle creams and, this sort of thing.
And I'm not opposed to those. I buy those things, but that is not where it ends, people. It is not where it ends.
So is this what you mean when you say aging with power?
Yes. You know what? It's so funny how everything circles back to the beginning. When I got out of my fellowship and started doing musculoskeletal aging research and started presenting it,
I chose the North Star of, in this career, I'm going to change the way we age in this country. So all of my work, whether it is, I'm a sports doctor, for God's sake, I am deeply involved in joint longevity. I do not want to have to send you to my arthroplasty buddies. I will. I often do. And when I do, I only send you to people who are whole person doctors who do outpatient joints and will get you walking and let you ski again if that's what you want, right? I choose like-minded doctors. But I am interested in joint longevity. And part of that are the cool things, the procedures I do. Part of that is the cool regenerative medicine that I do, harnessing the power of your own body. But a lot of it is lifestyle. A lot of it is education. And a lot of it is for women making your hormone, your menopause hormone decision.
Interesting. So, by the way, while we're still talking about aging with power, I've got to do the screenshot of your
buy this book.
Yes, of the book that's coming out on the day this episode drops, which is next Tuesday, 2 weeks from now.
August 26th.
August 26th. The book is called Unbreakable, A Woman's Guide to Aging with Power, and it's marvelous. What a gorgeous work. Thank you for putting this out to the world.
Oh, my pleasure. My pleasure. You know what? The people I take care of are smart people. So even though the cover says 6-week program for lifelong strength, yes, it is all those things. In fact, what you will find, I'm teaching people to start lifting from nothing to heavy lifting. What you find in this book is my last heavy lifting program. I mean, I'm not asking you to do what I don't do. It's in there, right? But because the people I care for are curious, smart people, the whole first section is science. How do we connect the time bombs of aging with estrogen and what it means to be a woman? Because this, my friend, is the first book on longevity written for the women by a woman who's lived it, who just happens to be an orthopedic surgeon and musculoskeletal aging researcher. So it's the first and hopefully not the last. Hopefully a lot of people chime in as they have done in men's longevity.
I think this book is going to sell very well because women want this information.
Thank you. Well,
my question to you is, did you come up with the title or did your publisher have some input here?
You know what? I have a colleague that wrote with me, and together we threw out so many titles. And the minute this word was said, we're like, that's it.
Beautiful.
That's it. Yeah.
It's when I heard from your publisher what the name was, it was like, push me onto the floor. What a great name. Like, it just captures you. I get it.
And I'm an orthopod, so it's a little bit of nod to.
Yes, of course.
Yeah.
And it draws me in. When you and your colleague want to have a voice together on how you wrote this book, should that be of interest, please come back on the show. I would love to have you both.
You know what? Writing books for me, this is my 6th book, and she and I both agree. In the middle of book writing, we both come to a point where saying, we are never doing this again. Ever.
Yes.
And then it's released and it helps people and we love it. And we're like, oh, let's start it going. So it's funny, if you ask us that question, we would both chuckle because we get to that point in this process.
Yes, that's fair. Isn't it true that that's what it's like having kids too? You're like, never, I'm not having another one. And next thing you know,
well, I often use the analogy, this is like birthing a baby. The pain of this is and then you forget it and you only remember the good parts.
It's the oxytocin. It's the same thing, right? Just without the breastfeeding.
Yeah, you're so right.
To be very feminine about it. Okay, so back to the MSM, the Musculoskeletal Syndrome of Menopause. Does it affect the pelvic floor?
Oh, well, that may be the whole next book. Because as I'm talking to people about jumping around and building bone, and every comment is, but what if my pelvic floor drops out? And I'm sure you've seen this. The fittest women in the world, the crossfitting women, when they're box jumping, it is not uncommon to see full on incontinence.
Oh my God.
Because the pelvic floor, I don't have a pelvis in this office. I have one in my work office.
Yep.
Is skeletal muscle. It
Yeah.
sits in the bottom of a basket and all your guts sit on top of it. And when you have babies, they sit on top of it and it just stretches out. And then nobody teaches us how to condition our pelvic floor other than they teach us Kegels, which is to contract, and that's wrong.
No, yes,
Kegels
absolutely
are
is.
sucking like slurping.
Yes, yes.
That's kind of gross. But so I think the 10 months after childbirth should be this whole like retraining of everything, right? Including the pelvic floor. Because so many women are doing these days what I did. I mean, my generation of women got married at 22, had babies right away, but I happened to wait to have my biological child until I was 40. And so many of the millennials are waiting till 35. And well, by then your skeletal muscle is also going away. So the pelvic floor is part of the musculoskeletal syndrome of menopause. But even fewer people know about the pelvic floor other than the manifestation than they do about bones, right? Fewer people. Fewer people realize that you can have therapy on your pelvic floor.
Yes.
That you can detect whether your muscles are clenching or not contracting at all.
Yeah.
And it can be the pelvic floor can be painful, but not only for women, pelvic floors can be extremely painful for men too.
Absolutely.
Interestingly. Yeah.
Oh, absolutely. I've learned so much working with a pelvic floor physio, just so much. Again, things I didn't learn as I was studying to become a specialist of the musculoskeletal system. It just was never taught. And we can only do better in the moment, right? So it's just one of those things where we're learning. But you know, that whole concept of Kegels is a funny thing, right? Like, oh, we've got to keep it tight. Well, we got to keep it tight for who? We're not keeping it tight for us. Oh, right, the penis that goes inside. Right. Okay. So when I have a woman say to me, I'm doing my Kegels, I'm like, hold up, sister. Like, there's a whole thing behind this that you need to know. And chances are most women have spasm.
Yeah, that's right. Exactly.
Just as likely as it is, in fact, probably more likely, yes, than
well,
and it's laxity.
That is what the head of my PT department, I have this great department. I hand chose all of them. She is a pelvic floor specialist. And she is teaching me that. That's how I even knew that we're clenching or spasming and not slurping, right? To make it function. So
I don't know. She sounds like she might need to be your next co-writer. I'm just saying.
Yeah, she's great. Yeah, she's fabulous.
I do find that in my clinic as well, I am in my clinic space, I am working with the pelvic floor physio quite often to help to resolve the hip issues that women come in with, the gluteal issues, the low back things that seem chronic. We need to have the conversation. It's not just, oh, you know, she comes in with a lumbar pain and just happens to have been incontinent. Well, oh, well, that's just what women go through. That's what my doctor says. Just get used to it. Get yourself some pads. You're fine.
That is such a terrible answer.
No,
that is the answer, but that is a terrible answer.
It is a terrible answer. Absolutely.
Can I give you an example?
Please.
If that were men, that would never happen. And listen, I love men. I'm married to a man. I have sons.
Me too. Yep.
94% of my colleagues are men.
Yes, of course.
But if we say to a man what you just said that we're told, which is true, get over the dripping, or here's the example I want to give you, get over the erectile dysfunction, that is never said. Such that there are 29 erectile dysfunction drugs. And when they're put before the FDA, when Viagra was put before the FDA, it was rushed through in 6 months because it was a national emergency. It was a medical urgency.
The penis versus the vagina in urgency. Yes, go on.
There are only 2 of those medications for women. And do you know that it took 7 years? And so I just use that as the example of what you just said. Like women are being told to pee on themselves, which is another reason that they have to go to nursing homes because it's hard to manage. That would never happen in the medical world of men.
Nope.
So I'm not really angry. I just get really passionate about it's so ridiculous.
Yeah.
The answers are so ridiculous.
Yeah.
But here's the thing. I think me, myself included, because I've put up with a lot in my life thinking it was just the way things were. Women are the 51%, Doc. We are the majority.
Yep.
So our experience actually
Yeah.
is the
Should be the
normal
standard.
experience. This
Yes.
is normal.
Yes.
It's not what our men experience. That is the abnormal.
Yes.
We're the 50, if you think about it like that, right?
Yeah, absolutely.
But yet women, we're just so willing to say, okay, I guess that's just the way it is for us.
It's neurobiology. It is the people-pleasing effect of the menstrual cycle, the hormone cycle up and down. Now, when that changes and we lose the hormones that make us,
and
well,
we
they make
don't give a care. What is that new club from Melanie?
Oh yes, don't care club or something like
The
that.
Don't
Yes.
Care Club.
Yeah,
Yeah.
So when we lose the parts of the system that make us want to have people like us, the people-pleasing bits, because that's what the hormones do. They go up and down. It was Dr. Luann Brizendine who taught me that. I love her. She's a genius. And when that's gone, then we can have these conversations, Dr. Wright. We can say, look, pull back the curtain and say, no, you're not broken. Somebody's just taught you to look at what you're experiencing from the masculine perspective.
Yeah.
And then there's compassion in that. You can be mad as hell, because that's what we all are. I quite often say in the office to colleagues and patients, if your practitioner isn't saying fuck a lot, they're probably not paying attention to what's happening in women's health. Pardon my French.
Well, that's good, because I always have to apologize and say things like, okay, I'm a surgeon and I tend to swear. Plus, I'm a sports surgeon and spent my career in locker rooms. So.
Yes, you have.
But that's right. If we're not incensed by what's going on,
we're not paying attention.
We don't know what's going on.
Yeah,
we're too occupied with something bigger than actually what's going on, or we don't care.
Yes, or we're numb. We can't care.
Oh, how about that?
We can't care because we're in a state of nervous system dysregulation into freeze. That happens a lot. It happens a lot. This is a beautiful book. I can't wait for for women to access this information in such a usable form. Thank you and to you and your co-writer for making this look the way it does. When you're ready to write the second book, please let me know. I'd love to have you back on the show. In the meantime, how can people find out more about you?
Yeah, you know what? Every single day I'm on Instagram and teaching on Instagram. So that's Dr. Dr. Vonda Wright, always. You should go to the book website, which is theunbreakablebook.com, because the website is launching an app, which is interactive.
Awesome.
So it's book material, interactive, with my brain dump of 25 years of taking care of people, so that you can get personalized information based on the data you choose to put in. So that's really fun at theunbreakablebook.com.
Okay, awesome. We'll make sure that is in the show notes.
Yeah.
I ask my guests, do you have a website as well that you'd like to share?
I do, Dr. Vonda Wright.
Okay, absolutely. Amazing. And I've been there. There's so much great information on there. So thank you
It's kind of busy. Yeah, it's a busy site.
But for being an educator, thank you. And I know that passion deeply myself. My job is not just the therapy. My job is to teach first. And doctor, of course, means teacher. So I think that means we're doing a pretty good job, you and me. What do you say?
I'm working hard at it.
Yes, you certainly are. I see you on Instagram every day out there showing us what to do. I know. I have a question for you before I ask you my final question. You talked about pelvic floor with the heavy drops or the heel drops and the stomping,
the jumping.
Yes. When I see that, here's what I go. My plantar fasciitis is going, oh, hell no. So what do you say to those of us that are worried about our plantar fasciitis or our pelvic floors? Do it anyways?
I say for plantar fasciitis specifically, they're different things in my mind. The problem not only comes from dishealth of the fibrotic tissue because of estrogen, it comes from poor mechanics. You have to think about
and most people don't think about this, but it's important how you walk. Your gait matters. The strength of the relative flexibility of your ankle matters, right? We tend to isolate joints like knee pain. Well, you can have knee pain because your ankle's too stiff or because your hip's too stiff.
Of course.
When to the answer to that question is, well, let's correct the root cause. It's probably not the jumping. It's probably you're under estrogen,
Yep.
or our mechanics are bad. Let's fix that.
I've got a crappy shoe on, or I'm not wearing my orthotics or something. Okay, got
or
it.
you don't have joint mobility, right?
Yes.
Joint mobility of the ankle, the big toe, and it's critical for foot motion. So
The most important. Okay, very good. Okay, the final question. Now let's wrap this up. Knowing what you know now, what would you tell your younger self?
Oh, had I known what was coming, I would have used my critical decade. I was in pretty good shape, but my critical decade between 35 and 45, during which I had a baby and was in the best shape and then got out of shape, knowing what was coming, I would have been completely educated. I would have identified my source of menopause hormone therapy. I would have started that probably 5 years earlier than I did. I would have gotten in control of my metabolic health. I just would have been prevention, not reaction. You can fix things when you're reacting, but it's better to never hit a wall with perimenopause to begin with.
Oh, I love it. And I think that's like a siren call to the youngsters, the ones that are still in their late 30s and early 40s that are going, what the hell is going on? And they happen to come across this show because they were Googling stuff and thought, well, maybe it's menopause. So thank you for that. Dr. Vonda Wright, I very much enjoyed our conversation today. Thank you.
My pleasure. Thanks for having me.
The information and other content provided in this show, or in any linked materials, is not intended and should not be construed as medical advice, nor is the information a substitute for professional medical expertise or treatment. We are doctors, but we aren't your doctor. Seek your doctor's opinion. If you or any other person has a medical concern, you should consult with your healthcare provider or seek other professional medical treatment. Never disregard professional medical advice or delay in seeking it because of something that you have heard in this podcast or in any linked materials. If you think you may have a medical emergency, call your doctor or emergency services immediately. The opinions and views expressed on this page and in this show have no relation to those of any academic, hospital, health practice, or other institution. Thank you.